Alright guys, let's move on to this humongous subject of congestive heart failure. There are a bunch of different subtitles on page 291 of your first aid book. I'm going to present this as one continuous progression of pathology, because that is what congestive heart failure is. I will make sure to highlight the points within the diagram because we need something to help us put together a thought process. First, let's just make sure we understand that congestive heart failure is not a disease. It is a clinical syndrome of the signs and symptoms that result from this underlying cardiac problem. Let's start with left-sided heart failure and discuss right-sided heart failure immediately after. There are two ways to understand heart failure. Number one, systolic dysfunction leading to heart failure. This leads to a decrease in cardiac output, which leads to increase in volume. So we volume overload our ventricle. To compensate, according to the law of Laplace, we increase the thickness of the wall by adding sarcomeres in series, so we have increased distension of the wall, and wall thickness to alleviate the wall tension that resulted from excess volume distending our chamber. The sarcomeres, again, do not add in parallel because this is a problem of volume overload. Instead, we add in series to help increase the thickness of the wall. Remember, thickness was in the denominator of our Laplace equation, which is wall tension equals pressure within the chamber times the radius divided by the wall thickness. And this adding of sarcomeres in series helps the ability of these to distend. This is like adding rope on end to end. You make a really long sarcomere, essentially, that can stretch out nice and big to accommodate this extra volume. How convenient that adding these sarcomeres in series also decreases our wall tension from the volume overload by increasing the wall thickness. This is advantageous at first until we hit our limits and overstretch the sarcomeres. Eventually, there's such a significant decrease in left ventricular contractility from this overstretch mechanism. So it's now just a big, floppy, thick, dilated heart. The most common reason for systolic dysfunction is what? Myocardial infarction. This should make a lot of sense because the myocytes responsible for contracting are going to die, and the regional contractile dysfunction will lead to volume overload because we do not eject appropriate amounts of blood. Blood will continue dumping into the left ventricle despite the volume overload already present within that chamber. Eventually, volume will accumulate, which will introduce the element of increased pressure. If you block a hose long enough, it eventually distends until the water builds up and you get this huge amount of pressure. Now, the ventricle will compensate, again, by increasing wall thickness by adding sarcomeres in series. This helps alleviate the wall tension created by the extra blood pushing against the ventricular wall. Again, the heart is being progressively distended by a progressively increasing end diastolic volume due to decreased cardiac output. The eventual volume overload or blood overload will back up from the left ventricle into the left atrium and then into the pulmonary veins and into the lungs. This is accumulation of pressure, right? So whenever you increase volume within a contained space, you end up increasing pressure. The pressure will back up all the way and increase hydrostatic pressure in all those compartments. So not only do we have the cardiac output or forward perfusion element failing us in systolic dysfunction, we can eventually get a backward failure. So there's a forward failure problem and a backward failure problem from decreased cardiac output and decreased ability to empty the blood within the left ventricle. This will eventually lead to a retrograde transmission of pressure, which is bad. This obliterates the pressure gradient for blood to drain into the left atrium from the pulmonary veins. You need a pressure gradient for blood to flow through all of these chambers into the left ventricle normally. So we lose this gradient because of the increase in pressure. This means that there's going to be backup of blood and subsequent congestion of the lung vasculature, which can lead to congestion of the right side of the heart and then eventually the systemic venous system. Now, the second way to look at congestive heart failure is a progression from diastolic dysfunction. In diastolic dysfunction, the initial problem is usually due to an excessively high afterload, or whatever you want to say makes it hard for those cardiomyocytes of the left ventricle to get adequate blood ejection. They have no problem contracting, there's just something that's really impeding them from functioning at a normal capacity to sustain cardiac output. They have to try really hard. In diastolic dysfunction, the initial problem is usually due to something causing high afterload, most commonly hypertension. The ventricle will compensate according to the law of Laplace by again increasing wall thickness, but there is not that distending element present. We are worried about how hard it is to pump, therefore we increase wall thickness to alleviate wall tension, except that instead of adding sarcomeres in series, we add them in parallel. And again, this is that term of concentric hypertrophy. This is concentric hypertrophy because the sarcomeres increase wall thickness toward the center of the chamber. This is bad because the thick muscle is not compliant, and we're obliterating the lumen of our left ventricular chamber. So a non-compliant muscle will not want to distend. In addition to decreasing the lumen, we're going to decrease the volume of blood that our chamber can hold, while simultaneously losing the ability of our chamber to accommodate any increase in blood flow that we might need in situations such as exercise. So poor compliance means the chamber can only accommodate a very small volume of blood. Therefore, diastolic filling pressure will increase dramatically. Think about it. Our very thick wall with a tiny little chamber, this volume is limited. Whenever you maximize the capacity of blood here, then you start increasing pressure significantly, very fast. This is the same concept that happens here. We get a backup of pressure, but the etiology is due to a diastolic problem, not a systolic problem. So this eventually leads to a decrease in cardiac output because not enough blood enters the left ventricle. So we have a similar situation of decreased cardiac output in both, except that in systolic dysfunction, it's due to hypocontractility, and in diastolic dysfunction, it's due to inability of the left ventricle to accommodate sufficient blood volumes during diastole. So both systolic and diastolic dysfunction eventually lead you to full-blown left-sided heart failure. Now let's discuss how this malfunctioning left ventricle leads to some of the elements associated with heart failure, starting with the decreased forward perfusion problem. So, left-sided heart failure, great diagram, let's talk about it. Number one, we need to appreciate here on this diagram that the first response to the low blood pressure from the decreased forward cardiac output, perfusion, whatever you want to call it, number one problem is that the baroreceptors in the aortic arch and the carotid sinus coming off the arch, remember, we have our three vessels, so the carotid sinus up here at the branch of the common carotid bifurcation, and then we have baroreceptors also in the arch itself. They sense a decreased blood pressure, and this leads to a sympathetic nervous system response. That is shown here in our diagram. Remember, this leads to release of catecholamines that stimulate beta-1 receptors on the ventricular myocytes, leading to increase in left ventricular contractility. There's also stimulation of beta-1 receptors on the juxtaglomerular. Remember, juxta means next to, and glomerular means that something is next to the glomerulus. So the stimulation of the JG, or juxtaglomerular cells, which are also called the granular cells, they're called granular cells because they have granules of renin. So these little vacuoles have renin inside them. And when you stimulate their beta-1 receptors on the outside, guess what's released? Renin. So now we have activation of the renin-angiotensin-aldosterone system. This decreased cardiac output activated the baroreceptor triggers, leading to an output of catecholamine molecules that stimulated beta-1 receptors in the juxtaglomerular JG cells to release renin, and stimulates the myocytes to increase their intracytosolic calcium because we stimulated their beta-adrenergic receptors on our cardiomyocytes. So this is the first step in compensation. The problem with heart failure is that the heart and the kidney are not on the same page at all. The heart is like, hey, help me out. I'm working hard to provide blood for all of you guys. And the kidney is just chilling down in the retroperitoneum, not hearing a single thing. It's stubborn, it's angry, it's not going to be getting enough blood, and its job is to filter blood, and it needs filtration pressure to do so. So this decrease in pressure essentially means that we are hypoperfusing all organs. But when you hypoperfuse the renal artery, the kidney gets angry. And when you make the kidney angry, it starts releasing a lot of hormones because it wants to make the blood pressure in the afferent arteriole of the glomerulus high enough so that it can filter the blood and get rid of waste products, because that's its job. Okay, this is an image from page 525 of your first aid book. I hope that seeing it again will help connect how the renal and cardiac elements come together in the downward spiral of heart failure. Let's resume with the question. What cells line the afferent arteriole and act like baroreceptors? These guys. Right? This is very important. So, let's resume with the question. What cells line the afferent arteriole and act like baroreceptors? So the JG cells also have this element. They're called granular cells also because they're stimulated to release renin, and boom, we have activation of the renin-angiotensin-aldosterone system. So at this point, we have activated two compensatory mechanisms. We activated the RAS system and the sympathetic nervous system. The problem with all of these is that they never stop, because the heart will only get worse. It'll never improve without interventional therapy. So the activation of the sympathetic nervous system and the RAS system are beneficial at first, but continued activation leads to a downward spiral failure process that eventually leads to continued decrease in cardiac function. Remember, renin release is not only activated by the decreased stretch in the afferent arteriole. The low glomerular filtration pressure tells the kidney that our body is hypovolemic. This makes the proximal tubular cells go wild, absorbing as much sodium as they can. So think about it. Here's our glomerulus, and this is our proximal convoluted tubule. There's a very, very low pressure here. So that means that there's a very low flow rate. So low flow, that means that the proximal convoluted tubule has no problem taking up everything. So that means that when we get over here to the distal convoluted tubule, there's a low sodium chloride load. And guess who does not like that? The macula densa. So the macula densa senses a very low sodium delivery to the cells of the distal convoluted tubule, and its job is to sense how much sodium it is sensing and control the glomerulus via tubuloglomerular feedback. That's a big word that you have to know. The macula densa will release prostaglandin E2 because the prostaglandin cells can make COX, which is a cyclooxygenase, which makes prostaglandin E2. Prostaglandin E2 will stimulate the afferent arteriole to dilate, and it will stimulate the JG cells to release renin. So that is another way that we can get activation of the renin-angiotensin-aldosterone system via the macula densa. They produce prostaglandin E2 and prostacyclin to relax the vascular smooth muscle and increase the diameter of the afferent arteriole. This will help increase the amount of blood entering the afferent arteriole. Now, we need to increase afferent arterial dilation to get more renal blood flow and filtration pressure. So in summary, there are three ways we can activate renin release from the JG cells. We can bind beta-1 receptors on them from increased sympathetic nervous system tone, hypoperfusion causing decreased stretch inhibition of these cells, and macula densa induced release. Now you guys are fully aware that renin cleaves angiotensinogen. Remember, anything that ends in OGEN is a zymogen or a precursor for the active molecule. So there has to be cleavage by renin to get angiotensin 1. Now, angiotensin converting enzyme found on the endothelial cells of the pulmonary vasculature further processes angiotensin 1 into this multitasker gunner angiotensin 2. I mean, just look at all the things it does. How efficient is that? I mean, that is just like number one, top 10 percentile in the class, doing everything. Angiotensin 2 causes vasoconstriction of the efferent arteriole. So again, here's our glomerulus. This is the afferent. This is the efferent. There are angiotensin 2 receptors here, and then we get an incredibly high level of vasoconstriction at the efferent arteriole, which increases the hydrostatic pressure within the glomerular capillaries. And this increases the GFR and filtration fraction, right? In addition to that, it stimulates the sodium proton antiporter of the proximal tubular cells to increase sodium uptake. It also stimulates aldosterone synthase to make more aldosterone from the adrenal gland. It tells the posterior pituitary to release antidiuretic hormone because we want to save fluid to increase our intravascular volume. So we get more aquaporin channels inserted in the distal convoluted tubule and the medullary segment to increase free water reabsorption. And again, it tells the hypothalamus that we are thirsty because when we drink, we get fluid and we increase our intravascular volume. So it's important to understand that it does a lot of things with the net effect to increase our blood pressure. We increase our blood pressure by retaining sodium, by telling us to drink water, and we increase our filtration fraction by the constriction of the efferent arteriole of the glomerulus. Now, what's important to realize here is that, yeah, we increase our blood pressure, which is good because we were hypoperfusing our organs, but the problem is we have systemic vasoconstriction. It's good for a second, right, because it helps our perfusion pressure to all of our end organs, but is this going to be good for the heart that's already struggling? No. This is how compensatory mechanisms can eventually lead to complete failure without appropriate compensation. If you raise the blood pressure, what are you doing to the heart? You're increasing the afterload that the heart must pump against. The heart is going to be working even harder to contract against this elevated blood pressure. And this is going to increase myocardial oxygen demand, which is MVO2. So angiotensin II wasn't even done yet in our discussion. Quite the multitasker. The main job of it is to tell aldosterone to get itself together and get in here and get in on some action by inducing aldosterone synthase. It's important to know exactly what aldosterone does. So let's talk about that a little bit more. So angiotensin II tells the adrenal gland, the medulla, and the cortex to release certain molecules. So from the zona glomerulosa, we get aldosterone. Makes sense, right? Glomerulus, the zona glomerulosa of the adrenal gland. So aldosterone comes from there. And then also angiotensin II stimulates the adrenal medulla to increase the production of catecholamines. Now, you must know that aldosterone is a steroid, so it can cross plasma membranes, and it is a direct transcription stimulator because that's what steroid hormones do. Let's check this out further because this will help us understand some of the treatment behind congestive heart failure when we get there later. So, this is a great diagram that shows what aldosterone does. As you can see here, it diffuses through the plasma membrane and it binds to response elements that then go on to the nucleus to transcribe things. So what do we transcribe? Number one, we put more of this ENaC, which is a sodium channel that increases the reabsorption of sodium. This is blocked by amiloride or triamterene because they are direct ENaC antagonists. Now, what else does it do? Number two, it increases transcription and insertion of ROMK channels, which are efflux potassium channels. That means that we will lose potassium and put it into the urine. So this is a risk of hypokalemia in people that have really high aldosterone levels, and hypernatremia because we're increasing our sodium reabsorption. Now, what else does it do? It also increases the transcription of the basolateral, this is the basolateral side here, the basolateral sodium potassium ATPase. Why? Because it gives us a gradient to pump out this potassium, which goes out through the ROMK, and continue to reabsorb sodium. And what follows sodium? Water. And we are increasing our intravascular volume, which is the main purpose of this entire mechanism. And remember, ADH puts in these aquaporin channels by stimulating the V2 receptor so that we increase the absorption of water, and water will follow sodium. Great mechanism to have an increase in volume, but not if you're chronically activating it. If you chronically activate it, it leads to deleterious consequences in the long term. This is why our drug therapy is structured the way it is. We use ACE inhibitors to block the production of angiotensin II because we do not want angiotensin II to stimulate aldosterone production. Again, and the benefit of that is that we don't get any angiotensin II to cause systemic vasoconstriction. In addition to that, the lower levels of aldosterone and lower levels of ADH are crucial. Remember, angiotensin II goes to the posterior pituitary and tells it to release ADH, and we don't want that. So ACE inhibitors are crucial in preventing this process. And again, we add beta blockers because the heart is already stressed out and the baroreceptor reflex needs to be inhibited at its end organ effector sites. So we block the beta-1 receptors on the myocardium, and we block the beta-1 receptors on the JAG cells to decrease even further renin release. What else is left to block? How about the actual aldosterone receptor here? And how do we do that? Spironolactone. Now, this is important to understand. We know the pathophysiology, and just by knowing the pathophysiology, we know the pharmacotherapy, right? You use ACE inhibitors, you use beta blockers, and you can use aldosterone antagonists, right? Perfect. So now let's shift from examining the deleterious effects of forward perfusion problems and see what happens when we check out the backward failure. The backward failure causes the increased hydrostatic pressure in structures prior to the left ventricle, such as in the lungs. And this is an important connection that we need to understand. So back to our diagram. Let's get refocused and put things together. So left-sided heart failure is a serious problem due to a decrease in cardiac output, which we called forward failure. And this is from the decreased left ventricular contractility in the case of systolic dysfunction, or a decrease in cardiac output from a non-compliant ventricle refusing to allow adequate end diastolic volume, which means our preload is low. So, both systolic and diastolic dysfunction eventually lead to heart failure. In both of the situations, you get a retrograde transmission of elevated pressure to the pulmonary vasculature, which causes pulmonary venous congestion. So the decrease in the left ventricular output leads to accumulation of volume and pressure, and this can transmit it back into the pulmonary venous system. Over time, you have chronic pressure within the pulmonary capillaries, and that leads to transudation and leakage of erythrocytes across the vessel into the alveoli. Remember the Starling forces that are always governing what those capillaries do. If you increase the hydrostatic pressure so high that you'll get movement of fluid across the vessel. If that happens for a very long period of time, you can start getting cellular elements to cross over, such as red blood cells. So the pulmonary edema can also be accompanied with some extravasation of red blood cells.